Welcome to another episode of the Toronto Catholic Doctors Guild podcast. My name is Pascal Bastien. I'm a general internist here in Toronto. In the summer, we had released a podcast showcasing the 2019 CFCPS conference keynote address. The Canadian Federation of Catholic Physician Societies seeks to promote, through educational activities and other means, such as this podcast, the teaching of the magisterium of the Catholic Church as applied to the practice and the provision of healthcare. I encourage you to have a look at our website, CanadianCatholicPhysicians.com, where you can learn about activities in your area. This second talk that we're releasing from this summer's conference was recorded on Saturday, June 1st, during one of our practical sessions. Its title is Discussing End-of-Life Options with Suffering Patients. It was given by Dr. John Scott, a palliative care physician at the University of Ottawa, who generously shared his 40-plus years of clinical experience and explored how to discuss death, hope, and goals of care with a suffering patient, especially in the context of legalized euthanasia. He certainly captured our attention. Have a listen.
I was a kid doctor across the road. That's where was my clinical hospital when I was in medical school. And then I was the first palliative care consultant back in the late 70s, early 80s here at St. Michael's. So it's really nice to be back. I have no disclosures, conflicts of interest to report. So how does a Catholic physician discuss issues like death, hope, goals of care in the new context of legalized euthanasia? And how can we accompany and respond with empathy while continuing to avoid cooperation with evil? This woman attempted suicide when she was told of advanced cancer. This is one of my first patients in palliative care. With the assistance of a lot of different people and a spiritual awakening, she came to actually view the last months as being the most fulfilling and most joyful of her entire life. She actually had been a model in New York. She loved cameras. And she said she wanted me to take this photograph. And she said, I want people to hear about what this new idea of palliative care is. And yes, I give you full permission to use my face to try to tell people about why I'm so glad that I wasn't successful in my suicide attempt. It's amazing privilege. I mean, all of you will have stories and people that have affected you, and how privileged we are in our vocation that we can be taught by them how to live more fully and how to come closer to God as we deal with them. And certainly Jean Vanier, who we think of recently very much so, taught us that to get close to those who suffer. And when we do so, we discover that we are the poor ones, that we will receive the gift of healing by the hands of those who we serve. So that patient-doctor relationship, that encounter, not a client, but a patient, the one who suffers, not a contract that we enter into, but a covenant. And it's a holy place, that relationship. St. Teresa of Calcutta opening the gospel to us, that those we serve are Christ in disguise. And while we are sometimes busy with life, I do believe that in my own practice, when I am touching all of those areas of suffering in my patient, I am touching the wounds of Christ. Some of you have either read or heard me talk a bit about lamentation. And I was thinking of totally avoiding lamentation because I've talked about it so much. And then it kept coming back as something That's how I frame what I do and how I talk to patients about suffering. So I'm going to still use that. That biblical concept has been key to how I understand the relationship of a physician to a suffering patient. And certainly, over the last 4 years, I've experienced lament about the decriminalization of euthanasia, the erosion of conscience rights, the frenzy of support, like even a surprising level of rapid support from colleagues that I thought I knew, and the culture as a whole. I grieve the hijacking of palliative care, having been involved from the beginning and seeing the vocabulary and even the control of programs being taken over by people who do not hold to the original principles of its founding. In early May, I was in Vancouver at the conference of the Christian Medical Dental Society of Canada, and the conference theme was Refreshing Streams, based on the promise of Isaiah 43:19, that streams would be provided in the desert. And just as our suffering patients find themselves in a desert, so do we, because this is a desert time for Christian physicians. And yet the promise, I think, is very important for us to hold on to, that it's in that desert that streams of refreshment and renewal are going to come to us. And our vocation as Christian physicians renewed. Lament across all cultures, both ancient and modern, both individual and communal. What is clearly a cry of grief, but it has strong notes of protest, rage, confusion, anguish. It's that why that we either hear with our ears or we see with our eyes in our patients. Precipitated by death, but in the biggest cultural context, could be defeat in battle, it could be rape, it could be invasion, exile, humiliation. The bagpipers lament. All my genetics are Scottish, and we're a doer lot. And we don't necessarily show our emotions all that well, but we make sure that we have a musical instrument that cries for us. And that reverberation that's really in the heart of the bereaved is being taken up by the bagpipe lament. And we see this global phenomenon of individual grief being caught up in communal lament that gives meaning and support and comfort. And yet our society, at the very time that says it's being comfortable with new death and choosing death, is very uncomfortable and is less and less having even a moment of pause about and sharing lament at the time of death. There is the stifling of lament. And what is the essence of suffering? Certainly if you have, as a physician, you have two patients, same disease, same intensity of suffering, one will experience that as severe suffering and another much less so. What's the difference? And so this study from a decade ago by Mountain and colleagues in Montreal of a qualitative research looking at why terminally ill patients would call their experience suffering. And that sense of disconnection was a very important thing for, in a sense, the disconnect from a number of things, feeling cut off in some way or another. And then the crisis of meaning. Interestingly, our last presentation, there was that mention about being preoccupied by future or past instead of being able to be in the moment. And that was something that came out in this research as well, in that, so preoccupied with the past in the sense of regrets, resentment, guilt, shame, or on the future in terms of being overpowered by anxieties, fears, hopelessness, and not being able to be in the present. And that seemed to be a characteristic of what was making that particular experience one of suffering. And then in 4 and 5, basically 2 forms of saying helplessness, sense of being victim, being out of control. So it is not the physical illness, it is not the symptoms, but it's this context of having a disease and having symptoms that are the key thing. I'm sure you will have experienced that as well. Suffering of all kinds is experienced as a form of death. It's a disintegration. Life is falling apart. Lament is a grief-filled protest against death, and yet it very often contains some type of call for death or wish for death. I might as well be dead. I'm as good as dead. So suffering evokes this messy mix of calls for life and calls for death. We, with our eyes, but even those who are working in palliative care without any kind of spiritual background, will often, as they listen deeply, realize that in every case, that cry for death remains at its core a cry for life. The lament in the biblical tradition, Tevye, Fiddler on the Roof, with his laughing through tears humor, and he's demonstrating, he's portraying that long-standing freedom of Jews to complain, to kvetch, to argue and cajole and bargain with the Lord. And yet there's also this beautiful intimacy that allows him to lament without fear. Scriptures are packed with lament. The book of Job, Lamentations, large chunks of the prophets, and approximately 1/3 of the Psalter. My God, why hast thou forsaken me? Why art thou so far from helping me, from the words of my groaning? O my God, I cry by day, but thou dost not answer, and by night, but find no rest. Why have you abandoned me? Why are you not listening? Why are you so slow? Why are you not keeping your promises? The pattern of a biblical lament starts with this cry of why, the protest, the anguish, the emotional intensity. This isn't a why of the cool philosopher. This is raw humanity crying out. And it's a process. It begins there, but it doesn't end there. There's a movement from one place to the other in a biblical lament. And again, even at the beginning, however, there's that note of intimacy. My God, both the word my and the repetition. There's a sense of trust that this psalmist is being able to cry out to God in a way of trust. Then we move into petition, trust, although even tentative trust. Not I trust, but our fathers trusted. So can I trust you the way our fathers did? Moving to thanksgiving, or again, sometimes more of a bargaining thanksgiving. If you get me out of this mess, I will give you thanks in the temple. And by the end, there is this, in almost all cases of biblical lament, there is this full-fledged praise, both at a communal and individual level. There's lots of tevye in biblical laments, and I'm saying that partly because I think that's the kind of lament we also see in ourselves and in our patients. Lots of drama, lots of messiness, full range of emotion and thought. In a sense, we throw everything at God, and we kind of throw it out and come back, and we try a number of things. And that is the nature of what I think we're hearing at the bedside. We blame God. we try to shame him. We say, "What will people say?" If you read a lot of the laments, what will people say that you didn't save your people? And we have this exaggerated self-defense, self-pity. I mean, I'm totally innocent. All of these, the bargaining that we mentioned and the intimacy, but definitely trying to control the situation in any way possible. But there is, again, this might as well be dead in one form or another. And in, for instance, Psalm 22, verse 15, "Thou dost lay me in the dust of death." So as he's going through the situation he's in, again, definitely some blame. You've left me in this dust of death, but it's also, they're experiencing this suffering as death, as almost worse than death. And the ultimate example is obviously the use of Psalm 22 by our Lord on the cross. "Eloi, Eloi, lama sabachthani." And there is no doubt that he was taking upon himself the entire psalm, which ended in thanksgiving and praise. But he no doubt also embraced at the beginning the lament, the anguish, and the sense of abandonment. The prayers of lament are a form of worship and faith. And one author has said, lament gives depth, nuance, and clarity to the story God is telling as people willingly surrender long-held beliefs, prejudices, and defenses. And it's that last part of the sentence that I was wanting to emphasize, because I do think that it's often possible for us, and if we look at our own lives, when forms of suffering comes, that we, as we lament, as we go in prayer, because lament is a prayer, as we go in prayer with honesty to the Lord, there is the ability to be freed from our prejudices and defenses and see things in a new way. Those who know how to lament are more likely to learn what the 12-step programs mean by let go and let God. Trusting relinquishment, recognizing we are at the end of our rope and we can't control the chaos and we let God take over. So let's go to talking about patience. This man in his early 30s, dying of small cell lung cancer, 2-year-old daughter giving him a kiss. Right beside him on the other side is a newborn son who had been diagnosed just before, had been conceived just before diagnosis. Within 3 weeks, he was dead. How do we, it didn't matter that I controlled his pain with opioids, which wasn't actually very difficult in his particular case. But that's such a small part of that man and his family's suffering. For me, the framing of that as lament has been critical for me staying in this work. I've been doing this since 1975, and people will often ask, well, how do you do that? And I do think that framing it of somehow feeling I am part of Christ's lament and part of a much bigger reality has been why it has been possible. The many faces of lament. We've already today, addictions and other self-destructive behaviors and dementia. It isn't just the chronic and terminal illnesses that we are dealing with. It's loneliness and spiritual emptiness and broken relationships. And they're all happening to someone who's also has a terminal illness. And it often does telescope all of that into the patient. So certainly someone who is being told that death is imminent often has a very focused intensity of suffering. And of course, their lament is so easily misinterpreted in this age of legal euthanasia. That cry for help and meaning is often messy and contradictory. I desperately want to live. I'm afraid to die, but I can't go on like this. Help me to die. In the same sentence, in the same paragraph, people will flip back and forth, back and forth. I have seen that throughout my whole career. Now it becomes extremely dangerous for someone to start to speak that way in our environment. People don't understand what that lament is and too quickly see it as a request. Behind the specific words, there's far more. I might as well be dead. I wish I were dead. Let me die, help me to die. I want the needle. When someone says, I might as well be dead, John McCormick and I were just talking about this before, I might as well be dead. What are they asking for? They're wanting you to contradict them. They're wanting to hear, is there anyone who thinks that the wording and the various forms, we need to listen deeply. And the problem is right now, and I say this for myself, as a Catholic physician, we start getting scared. When someone starts talking like this, we think all about CPSO, we think about all of these things that we're going to be threatened potentially by this, and it interferes with our ability to be totally present to the patient because of our own fears and defensiveness, and what are we going to say next? Certainly family are a very important part of this, and I often see as the patient comes close to their death, their lament begins to resolve, whereas the families start to have a crescendo, and increasingly families are not willing to wait, and we're having many families now asking us for euthanasia, even for incompetent patients. And obviously at this point, usually, hopefully, our colleagues will also say no, but it already has changed what's being asked by families at the time of death with an incapable patient. Lament in the era of legalized euthanasia has become very complex. There may be a qualifying illness on the paperwork, but often the suffering is unrelated to that disease process or very peripheral. So in my experience, both with oncology, but even more so with non-cancer patients, a large proportion of patients have mental health problems. It's not documented. It's not going to come out in the studies because the assessors aren't putting that in my experience. They're looking at the qualifying illness. They're saying the patient has suffering, but they're not analyzing what we would be seeing. So, for instance, two patients. Like I could give you 10 stories right now about mental health issues that are the real core of the suffering, and they're just finding a cancer or some other to qualify for this procedure. But two patients, pre-existing depression problems with suicidal attempts, brought into hospital because of a suicide attempt and kept in hospital until they received MAID. Because in one case had a cancer and another case had a previous cancer that might recur, and they were 81, so they were also, death was in the foreseeable future. So this is happening around us, and I mean, even there, you can tell by my voice that the frustration and the anger that sometimes arises in us because we feel our patients, our vulnerable patients, are being hoodwinked, literally, as this all happens. Suffering may also arise from a lack of appropriate healthcare resources, not from the disease. Had one lady who wanted to go back, so a Catholic hospital, because she had chronic illnesses, bilateral amputation, had been there for a while and loved it, and she said, I'm the queen of the place. Everyone comes to me, I go to all the programs, I love it. And she had an intercurrent illness, brought to acute care hospital, and she was turned down for transfer back. And so she was told she had to go to long-term care. And she said, I can't. I will. She was cognitively normal. Her view of long-term care was so negative, she said, I would rather die. She applied for MAID. 2 assessors said she qualified. They asked us to get involved to help with her symptoms until she died from MAID. I heard this whole story. Again, the angst in us as a team to know what to do. And I mean, I got on the phone to another Catholic physician and said, I'm going to send another application over, and I'm going to explain all the situation, but this is also part of the story. She was accepted. When she was told that she would be going back, she said, oh, thank you, I'm so excited. I didn't want to die. This is so good to be able to do this. Thank you, thank you. And you think, instead of that relieving my lament, it almost hurt me more, the thought that this one patient, this is happening to, but the story's going to be very different in many, many other stories. Another part that I think you may or may not know is the problem of patients in the last 2 weeks of life who are waiting for MAID. Generally speaking, a lot of them have their drugs diminished because everyone's worried they're going to lose capacity. Their pain relievers, their antiemetics, their psychotropics are all being lowered so they won't lose capacity, which tells you, first of all, they're close to death and they don't really need this procedure. Second thing it says is that it's being suspected they're on the edge of incapacity already, or they wouldn't be worried about this. But as a result, the last 2 weeks of a significant number of patients are having increased suffering, increased symptoms because of holding back. So the very procedure that's supposed to take away suffering is actually making the last part of their life worse. Again, is that going to get documented in any of the studies? I don't think it will, because they will look at the assessor's consults. So, hidden lament. In this era of legal euthanasia, I see more and more frequently this stifled or hidden lament. So it's not uncommon to see some people who say, no, I just want to get this done with. No, I know I have to say I'm suffering, but I'm actually not suffering. And if I ask them, well, are you afraid you're going to suffer in the future? Which some people would say, yes, that's what they're afraid. Some of them will say, no, actually, I've noticed palliative care. I think you could take care of all my pain. But I say, why wait? I want to do this on my own terms, in my own timing, and let's get on with it. No room for grief. If you try to explore what they're feeling, they don't want to talk about feelings. They don't want to talk about grief. They don't allow grief for their family either. This has to be, it's all about this act of control, act of affirmation of what they want. And yet, if you scratch the surface, I mean, that would be so irritating because you feel like this is fake. But you know that if just a few centimeters down, there's a scared person who's feeling out of control and is grasping for control. But sometimes we can't reach it. So, conversations. I mean, the literature tells us we should be looking at signs of mortality, issues of prognosis as our key, which I would question in the sense that it doesn't mean that this is an important factor, but I don't think it's the key to knowing how to time our conversations. Obviously, the patient hopefully will prompt a lot of the discussions, but sometimes we have to be the one to do it. Using performance status, another way of, in a sense, another form of prognostic trigger. But in Ottawa, we're rolling out 2 different tools to try to prompt goals of care discussions. For hospitalized patients, this new Homer Now, some of you may have heard of it, Carl van Walraven, and which is looking at the prognosis of 1 year survival in hospitalized patients, which has actually shown very high sensitivity and specificity. And RESPECT, which is a very different kind of model of an elder life calculator that Dr. Tanasaputro has done. And again, these are conversation triggers that are being used. And then conversation guides. We can look, there's a lot of them around. Some of them patients can do some work themselves, can't substitute for talking to physicians. This is one that I have used, which is developed by the Harvard Palliative Care Group, and it's being used in the Ottawa Department of Medicine. So if the Homer Now says that they have a high risk of dying in the next year, then this type of agenda is being proposed to the members of the Department of Medicine to use. The outline is simple enough, but I think the important part is, if you looked it up, it's the questions. I think we all have to keep gathering good questions and try them out ourselves. You might see another clinician use a question in an encounter with a patient, and you think, oh, that was so good. That really worked. And then it's sometimes a surprise. You try it out yourself, and it falls flat. It's sort of, oh, that's not me. Now, sometimes that just needs practice, but it often is that we need to have a variety. And it may be that was the right question, but the wrong patient. And we have to have a real toolbox full of really good, rich questions. And sometimes when we're in practice for a while, we don't get a chance to talk. We don't watch our more experienced colleagues. We are sort of, we're seeing students sometimes, but we don't necessarily get a chance to hear how someone else is talking to the patient in this kind of context. We all know that even on a busy day for any of us, like I'll often tell the students who feel, oh, I don't know what to say, and I say, I don't know what to say either. And I'm supposed to be the one who does this every day and has done it for years. That's actually a kind of a gift. I'm going to talk about that in a minute too. A gift of not knowing quite what to do. Cautions about those conversation guides. Use them, but use them for advanced care directive goals of care, and not necessarily for listening to the story of suffering. And it is important to get those advanced care directives and goals of care, because I actually think there's a huge amount of meddlesome medicine that continues to ramp up. And in many ways, that is causing a lot of our problems. We are not controlling our use of technology. We're continuing to prolong dying in a way that is bad for the patient, but it also, I think it promotes, and a second thing, someone was asking me, are patients in palliative care more difficult to control than than years ago? And I would say absolutely. The symptom management is much more difficult, and it's partly because we're so good at prolonging life, but we don't want to unnecessarily stretch that out for a few more weeks or months when there's no benefit, because in fact, we're going to cause patients to have symptoms we can't control. And we have to weigh that when we're offering various things. I mean, even now, we save people in the ICU, and then we say we have nowhere to care for you. Every single day we see that. And we need to put the whole package together. If we, and I think, I can see by the nods that there are a few people who would identify with that. So it's critical for us to teach patients and families at least talk with patients about what natural death looks like. Get them to read, for instance, these kind of guides. These would be for patients where patients are close to death, within weeks of death or days, that they could look at what the normal pattern of symptoms are at when death is close. Again, always use a moment when you could walk into the patient's room and family are there, and this is a patient who is close to death. Use that as a moment to teach, because I say out loud what I'm looking at. I say, you know, when I look at your husband, I'm actually looking at the tension in his face, which I don't see any. I'm looking at the breathing, which you may think is noise, but in fact it's regular. I'm not concerned about that noise. There's a little bit of fluid that's going back and forth around the vocal cord, and I'm anticipating all the possible ways in which they'll interpret what they're seeing as suffering, and I'm reframing it as normal. It would be like listening to a snore, and I'll have a whole little bit of spiel. Sometimes I think I may be giving more information than they really need, because they may not be worried about it, but I don't want to take a chance. And so often we hear of people, they come up to me after a public meeting, and they'll start telling the story of their husband or child or who has died a horrible, suffering death. And yet, many times, as they give me the details, I'm thinking this was probably a normal death without severe symptoms. 10? Okay. But, so, I think that I've said it more than enough with that. Dignity therapy, Harvey Chochinoff, really good set of questions, but also the idea that we can make an impact by allowing a patient to contemplate their legacy, their stories, and to hand it on to someone. This is showing huge impact on a variety of parameters like sense of dignity, sense of purpose. So that's a whole set of articles that are available, and I would encourage you. Empathy, but I would prefer the word compassion, a little bit fuller, a little bit deeper, a little more in tune with the whole history of Catholic healthcare. To suffer with, to at least lament with Christ, and as lamenting with him, I believe he lets us, in as much as we're able, to enter into suffering with him for and with our patients. And part of that is I'm going back to that sense of vulnerability, to be aware of our vulnerability, even truly our helplessness outside of God. And the moment of vulnerability is a gift from God. Don't know what to say. I think I've actually done this the wrong way. I feel foolish. I got the wrong patient. We've all done that. We've got two patients mixed up, and we're at the bedside, and we say something, and we realize, oh, that's the other patient. And we feel foolish. We feel, and we want to just go, and to say at some point, yes, we have to get out of that. We're not wanting them to be upset, but to almost say, thank you, Lord, that in some small way I can share in the nakedness and vulnerability of my patient. If we have just 10 minutes, I maybe even will leave it, stop there and ask if there's...
More of a comment, something you were saying about the observing older mentors. I had a patient die at the nursing home last fall, and one of our older doctors, who's also a palliative consultant, I asked to help. It was a relatively straightforward situation. He just helped a little bit with medications, but the most meaningful to me was when we went in together, this older doctor and myself, and the whole family was there, and I got to watch him, this guy who's been a palliative consultant for 30, 35 years, and to watch him, now that I'm a physician and do this myself, was way different from when I was a learner, right? So just appreciating that mentorship even 7 years into practice, to see somebody who's been in it for far longer than me, to see his style, to see little subtle things that he did, was really a nice experience. So, I was like, how can we do that more often? Just to get a colleague coming in and just observe, wow, that was a neat way to say that,
I mean, I think partly telling stories, it's the second best, but telling the stories to each other about cases, and not just the traditional, but actually saying chaplains are better at doing verbatims and actually remembering what we said and what the patient said, and then kind of analyzing it. Sometimes that would be helpful. I mean, I just noticed one thing, for instance, coming to realize that saying, I'll often ask a patient, both alone and with a spouse, saying, how is your spouse doing with all of this? Or how are they coping with all of this? Now, if the patient's alone, and it especially is men, but it can be both genders, will tend to project their feelings, especially if they're people who aren't comfortable with their feelings. They'll project their feelings unwittingly onto their family member. And it allows you to understand what's going on a lot better. I then sometimes will do the same thing when the spouse is present, but it's for a whole different reason. So to say, right in front of, I'll say, so how do you think your wife is doing with this? And they'll sometimes do eye contact, who's going to say what, and sometimes one or other, usually the patient will try to say something. And what I'm doing is trying to get them to talk and get them to start thinking and talking together, and you're trying to create a catalyst. So that's a very simple little phrase that I almost every day, I would do that with multiple patients.
I'm curious how you draw the line between the compassion, the suffering with the patient, and maintaining professional boundaries.
Yeah. I think you need to know clearly what your boundaries are, what you will or will not do, but I don't think you have to put the focus there. And the trouble is, it's new to us, so I think there's a tendency for us to be putting a lot of emphasis on clarifying our own boundaries, so that we're a little frightened of the boundary part. To get comfortable with those boundaries, know what we will not do, and then we can pour still our focus and all our energy on the core of what we are offering, which is really what the patient is wanting and needing. And Larry was saying it too today in a different way as a lawyer as well. Don't stop doing what we're doing. And I think we have to continue to have these conversations and take the risk of going in directions that might mean that we'll have to clarify our goals. Often you don't have to. You end up, patients will go back and forth and talk about dying and talk about living, and you need to listen. You have to validate their suffering. You don't jump into trying to minimize. You see, there's so many ways in which we can react badly to the lament. We can be like Job's friends and actually start to aggravate their suffering by our own lament that we're upset. So do try to not put too much emphasis on that in the encounter with the patient. That doesn't mean we don't. Maybe there's more of a specific question you have of a particular boundary that you were concerned by, but Yeah, I mean, I think that I'm going to just end with this one, because I put it in near the end of my preparation, and I was thinking, all this talk about what's the right way to talk to patients and what the literature says, and it came to me, when I am suffering, what do I want to hear from the Lord? And it comes down to very, very simple things. And I think we're going to do some of that communication with our medication titration, with making a good plan, with community care, with everything else, but it also is communicating these basic gospel messages from the Lord. We need to hear it, they need to hear it, and what a privilege. So, thank you.
That was Dr. John Scott from the Palliative Care Department at the University of Ottawa, speaking at the CFCPS 11th Annual Conference held this summer at the Lee Cushing Institute at the University of Toronto for a talk entitled Discussing End-of-Life Options with Suffering Patients. For those who attended the conference this summer, or those who have browsed the CFCPS website, you may remember that the Toronto Guild offered to the Canadian Federation an icon of the Synaxis of Holy Healers. I cannot skip this detail that today, first Sunday of November, on which we are releasing this podcast, coincides with the Byzantine feast in honor of these unmercenary physicians. So I will simply end with an excerpt from the Stechera, normally sung at Vespers on the Saturday night of this feast. Together let us now hymn all the valiant unmercenaries who bear a common title, our divine guardians, who with the zeal of faith and love for God gave themselves over steadfastly to the common good of all, for whom they suffered much for Christ, and who pray with boldness for the salvation of our souls.